Okay, madam, I think we are live and you can start.
Yeah, hello everyone. I welcome you to this session on severe PCO ovulation induction in IUI cycles after a break of almost like 2 weeks, I think. So since Dr. Jay was quite busy in his endoscopy work across India. So this, as you all know, is a very important topic which needs to be discussed, and also it needs to be emphasized that clinical and practical tips that are going to be useful in everybody's practice and not just the theory part of it. So the pros and cons of using various protocols, and also what else that we can add to make our stimulation protocols, especially in severe PCOS, successful, will be spoken by Dr. Jay today. Over to you, sir.
Okay, so I'll be sharing the screen, and Shilpa madam, please stay this thing unmuted. And can you see the screen?
Yes, sir.
Okay, fine. So now is it visible? I have just signed on J.
Yes, yes.
Fine. So it is important to understand that when we are trying to talk of ovarian stimulation, okay, in severe PCOS, and in today's class, we are only going to be discussing in severe PCOS, what do we want to give them as far as natural intercourse is concerned or IUI cycles are concerned. Okay. So in order to understand this, all we must know is that this is typically done when AMH is more than 9. Okay. So that is our typical identification of severe PCOS. There will be some people who will also look at the ovarian architecture and say that either the stroma is very thick, okay, on ultrasound diagnosis, or there are multiple follicles, antral follicle count of more than 15 to 20. And sometimes some people say that whenever you have such a severe picture, that is also called as severe PCOS. Okay. Another important thing which people try to emphasize is they try to label something as severe PCOS, especially when there is a previous failed attempt. Okay, so previously failed normal stimulation. Okay, so what I mean to say as normal stimulation is that your standard letrozole protocol of 2.5 mg, which was given once in a day for a period of 5 days, has basically failed you. Okay, and this is also where something you can label it as a severe PCOS. Now, I just want to tell you 2 or 3 important things which you have to keep in mind irrespective of what you do. Okay, and the first thing which you should remember is trigger. The reason why I'm saying trigger for ovulation induction and natural IUI cycles in cases of severe PCOS is because, especially because of this thick stroma, it is important that you standardize your trigger to 10,000 HCG. Kindly don't worry about OHSS in this situation. Standardize the trigger to 10,000 HCG, and that is something which is really, really going to add a lot of benefit to you across the board. And the second is luteal phase support. Okay, please remember, when a patient is with severe PCOS, there is already an abnormal, okay, there is an abnormal LH, okay, which is secreted, as a result of which abnormal corpus luteum is formed. Okay, and because of both these things, you need to give progesterone in the form of luteal phase support. So we prefer to give gel, which is our standardized approach. Okay, so this is something which you have to keep in mind very, very thoroughly. So what this does to you is this simplifies so many things for you. You already know what is your trigger. You already know what is your luteal phase stimulation. The only question mark remains for you is that, is the patient going to be following a natural intercourse? Is the patient going to be following an IUI protocol? And simultaneously, you can divide severe PCOS into 2 main subcategories. One is an obese severe PCOS, and the second is a thin severe PCOS. So now when this obese severe PCOS patient is trying for natural intercourse, the practical standardization, okay, the absolute practical standardization in both these situations is to straight opt in for an extended letrozole protocol. Okay, this extended letrozole protocol in an obese lady is going to be 2.5 milligrams morning, evening. So 5 mg dose to be given for approximately 8 to 10 days. And in a thin patient, it is again going to be 2.5 mg You can give it as a single tablet practically for 8 to 10 days. Now the question arises is that when we are trying to do natural intercourse, our target is to have a monofollicular development. All right, this is the target. But the problem is, whenever you are having an obese or a thin severe PCOS, you will see that recruitment is often delayed. Okay. Whenever this recruitment is delayed, this recruitment is typically delayed due to an abnormal LH and an increased androgen. Okay, both these things can cause the delayed recruitment. So as a result of which, this 8 to 10 days is your take home point. Okay, you must take home this 8 to 10 days. People often give it for 5 days and then get upset that nothing is happening. When you call the patient again for an ultrasound, let's say on this 10th day, and if you find that the follicle has been recruited and the follicle is, let's say, approximately between 12 to 14 millimeters, then in this situation, kindly do not hesitate to add approximately 150 international units of HPHMG to these patients. Okay, in both the situations, 150 international units of HPHMG can be safely added for approximately 2 to 3 days if at all you require, following an extended letrozole. Okay, please do not hesitate in doing this. Obviously, as I have taught multiple times, should there be a discrepancy between the developing follicle, okay, and the developing endometrium, feel free to go ahead with a half dose antag. For people who have not seen that masterclass, that's a beautiful masterclass and it will help you in this situation. Practically, I have never used the low dose HCG protocol in these situations, but I've heard some people doing that. I have never used it. Okay. Now, whenever we are trying to opt for IUI cycles as compared to this, target for development is 2 to 3 follicles. And please remember, the standardization here for all the patients mandatorily is to give extended letrozole plus HPHMG. HPHMG we standardly give as 150 international units. You can give extended letrozole plus HPHMG as a standard for 7 days in both the situations, in obese as well as in thin. Okay, just in case needed, as I said, plus minus 2 days extra. Okay, is what you can try to do, and usually you will have 2 to 3 follicles which are developing. Again, this problem of 2 to 3 days extra typically comes because of a recruitment delay, which is common in patients who are having severe PCOS. Now, before I conclude this session and before I conclude my 10 minutes, I want to mention very important in patients of severe PCOS, which people really need to understand and discuss and keep in mind, is the nature of adjuvants. Okay, so please remember that whenever we try and talk of adjuvants in patients with severe PCOS, people often think this adjuvant will help, that adjuvant will help. So in my opinion, the primary adjuvant of choice is metformin. If the patient has been continuing, that patient can continue. Vizolone, that is prednisolone or any form of steroids, any form of inositols, dechiro-inositol, myo-inositol, any form of coenzyme Q for the oocyte. Okay, all these three things, in my opinion, have an absolutely unproven benefit. Okay, so you may or may not experiment with those type of things. Metformin is something, if the patient is already on, you need to continue the metformin. It may help in slightly better recruitment, but it doesn't really guarantee any gross or drastic improvement as far as the pregnancy rates is concerned. Okay, very important. One more final thing, in all these situations, we already discussed trigger and luteal phase support. Please remember, you will have sometimes, especially obese and severe PCOS patients who have associated diabetes, mellitus, and associated hypertension. Please allow them to continue all the medications which they are on. Often, once the urine pregnancy test is positive, you can change these patients to the desired molecules which are safe for pregnancy. All right. With this, practically, I finish the session as far as discussion of protocols in IUI cycles for these patients is concerned. And I will be happy to answer 2 to 3 questions if there are any before we conclude this session.
Okay, yeah. So let's start with the classification of PCO. See, among, like you said, severe PCO, but you never included like hyperandrogenic features or oligo ovulation or the PCO morphology. Among these, which one do you think is more important when it comes to stimulation? What is the factor?
Yeah. So honestly, the factor which affects the maximum as far as ovarian health is concerned, okay, that is going to be androgen index. Basically, the higher the androgen levels in the body, the poorer is going to be the ovarian response to anything. Okay, that is something which ultimately nobody can change. And as a result of this, whenever we call this severe, as a result, there is this recruitment delay because of our hyper androgenic state, which is why I mentioned that you need to give extended letrozole for 8 to 10 days. People often will get very good outcomes in 7 days, but in severe PCOS, you will see that even after giving it for 7 to 8 days, 10 days, whatever, the follicle would have reached 13 millimeters. In this situation, one should not hesitate, okay, to give that 150 international units of HP-HMG to the patient for 2 to 3 days, because it is going to be a prolonged follicular phase. This prolonged follicular phase is mainly due to delay in recruitment. Because
Yeah.
once recruited and once estrogen receptors have developed on the follicle, it is very important to understand that follicle doesn't really care about the rest of the androgen. It is self-sufficient. It is like an Atmanirbhar follicle. Understanding? And that is something which is a conceptual understanding which we have to keep in mind in severe PCOS.
Yeah. So, and coming to, like, starting the stimulation, because there is a long follicular phase. So usually we start the stimulation on day 3. But in PCO, is there a margin where we can start the stimulation on day 6 or day 5? It doesn't.
Most of these severe PCOS patients might also have chronic anovulation. And if you actually see, you can start it when the patient comes to your clinic.
Yeah.
Unless there is a dominant follicle. See, unless there is a dominant follicle which has been recruited, due to an escape from androgen, very rarely it will happen, especially in thin PCOS. You can just start the day patient comes to you.
Okay. So tell me this. I mean, when do you suspect that this patient could go in for an OHSS? Even before you start the stimulation, what are the factors that you keep in mind when you stimulate somebody who might have the tendency to go in for OHSS?
It is important on what is your target. See, the reason why I said natural intercourse stimulation and IUI stimulation, maximum you want is the highest you want is 2 to 3 follicles when it is IUI. Okay. At that situation, the possibility of going into OHSS is not that great. Understanding? It is a very small possibility. The minute you think it is going to be a hyper response to stimulation, we are not going to give HCG trigger. Please understand, we are straight going to give decapeptyl trigger and the patient is going to go for a freeze-all. We never do this dual trigger in natural intercourse cycles and IUI cycles, and we have answered this a million times. And every day we get one patient who has had a dual trigger in natural intercourse. Patient has not become pregnant for 3 cycles. The patient comes to us. We do nothing about it. Nothing. We just ask them to try naturally without stimulation. And in 2 months, the patient is pregnant. See, that patient was not pregnant because of an incorrect trigger, which is why I mentioned trigger the first. Because in severe PCOS patient, doctors get so desperate, okay, that they try to add whatever they want to add and try to finish off, and somehow the follicle should rupture. That's really not indicated. You allow nature to do its time, and nature will do it much better than what our drugs will do.
Yeah. And in cases like where 2.5 mg extended protocol has not worked, so do you step up with 5 mg or do you still
I
want to?
don't like to step up, ma'am, because what happens is that too much of letrozole, no, it then goes and affects the endometrium. So I don't really like to step it up. I like to keep it standard at 2.5. If needed, I will add HMG inside the cycle, but not increase letrozole. I will add HMG if needed.
So when do you add HMG? From day 3?
No, I mentioned if it is a natural intercourse, then unless on day 10 there is a developmental recruitment follicle, which is, let's say, 13 millimeter, 16 millimeter, maybe 1 to 2 days I will add. Otherwise, for natural intercourse cycles, it is just letrozole because I want monofollicular. If it is IUI cycles, I already mentioned, I will give letrozole plus HP-HMG for 7 days plus minus 2 days.
Okay. And many a times, like, till what day do you wait to cancel the cycle? So you have given 10 days of letrozole. And after that, I have never seen anybody say responding after 10 days of letrozole. I don't give it beyond 10 days.
That cycle has to be cancelled. If there is no recruitment on that 10th day scan, you have to cancel that cycle.
Okay. And do you do this overlap of giving letrozole from day 3 to day 7 and then add HMG from day 6 to day 9? Is that something that you would do?
No. Only if needed in natural intercourse cycles for maximum 2 days of HPHMG, provided on day 10 a recruited follicle is around 13 to 15 millimeters.
Okay, and see, many a times we see that in PCO, the size of the uterus is slightly less. Okay,
Yeah.
and also the endometrium is also thinned out.
Yeah.
In spite of having a decent size of the follicle. So one thing that we can do is give that half dose antagonist, which I have also after your class found it very helpful.
It's very, very good, madam. Half dose antagonist.
I mean, yeah, it's actually very good when you want to the endometrium to catch up the follicular growth. I mean, it works excellently well in synchronizing the both. But is there any role of giving say arginine sachet or using
No role.
sildenafil or using estradiol valerate, estradiol hemihydrate in these
No role.
kind of.
There is no role of doing all that. Allow the follicle to go and stimulate the endometrium naturally. The more you top it up with any of these agents, the less is your outcome. That is the reason when you are doing an HRT-induced endometrial preparation, you want the ovary to be absolutely quiet. You don't want the ovary to be active. You don't want a double action to come on the endometrium. Single action is enough.
Okay. And beyond what AMH levels do you say that you're not going to stimulate them for natural intercourse or an IUI? You would suggest directly to go for an IVF with a reduced say success rate or getting a good quality oocyte?
Many a times when AMH is actually more than 13, 14, you will see that despite all these things, what you are doing, no, there is no response to the ovary. Actually, these are the ovaries which have this beautiful effect when you do an ovarian drilling inside them.
Yes.
Understanding? And that ovary post drilling will have a very good stimulation. Honestly speaking, this is one role of ovarian drilling which is still existent. But otherwise, if the patient is not willing for drilling, then you have to straight go ahead with IVF. And remember, when you do IVF, start your dose at 300 or 375 because it is an already resistant ovary. Don't do an iatrogenic poor response by giving 150 international units. Even in IUI, we are suggesting 150 international units. So in IVF, you should have a straight higher dose of recruitment.
And what about say the drilling that you mentioned? Okay, so in these drilling, how do you decide? Like, do you decide on the drilling based on only AMH, based on the thin PCO, based on the ovarian stroma morphology? What is it that makes you decide on the drilling?
Non-response to stimulation. Forget all the other criteria.
Yes.
Don't go by any criteria, madam. Just forget ovarian volume, this, that. If the patient has been non-responsive to stimulation, you can try drilling. Drilling will not work in all patients, but you can try to drill the patient. Okay. And in that situation, you will see out of 150% patient will start responding.
Yes, yes. I think this is very important where we have to consider the previous response in making a decision on the drilling. And what about role of clomiphene citrate? I mean, do you ever consider putting them on clomiphene citrate at any given point in time with
No,
any?
madam, not in my practice. No role.
Okay, so I think, yeah, that's about it. The rest we can discuss in the groups if it is okay.
Absolutely.
Yeah. Thank you, sir. Thank you. It was wonderful. I think this is one of the most, I think, requested topic that I have received. So I think you did justice by giving a lot of practical pointers for everyone to help in their